Hi, everyone. We'd like to get started. We've got a few speakers ready at the podium. So we're going to start with a short talk by Frank Scheuermeyer about one of the research projects he's doing, and then we'll launch right into the Ultrasound Fellows presentation, followed by 2 R3 presentations. Thanks.
Hey, thanks, guys. Let me just load this up here. Slideshow. And there's no presenter mode here, so as usual, is this planning to show up here?
Yeah. Switching all sorts of different things here.
So as usual, PowerPoint mangles the talk beautifully. Look at that. Not even the right font or anything like that. Anyway, quick research update. We do this once every 3 months. I think we've done this a few times now. Just ongoing project thing. RACT David is up to how many patients? 48, perfect. Alrighty, it's going well. Take-home Subox. Andy, if you want to quickly comment.
About Suboxone. The take-home Suboxone, so we had about a 12, 13 go out in the last couple months. Preliminary reports have been good about half of those people being on Suboxone on follow-up. So that's been good so far, but we just need to get more out the door, and I'll be talking more about that.
Excellent.
Can I ask a question?
Yes.
Just Danny about that. So if you have someone and you say, are you interested in kind of stopping or changing your lifestyle, and they say no, are you still saying, well, why don't you try this take-home Suboxone anyway? Because maybe if you get between a rock and a hard place, you'll like it. And I mean, is it people who clearly say, I want to stop, but I have to go now or whatever?
Thanks for that, Eric. I think it depends how you pitch it. If you say, would you like to have something just in case you're in withdrawal and you want to use something else beside going to your dealer? I mean, there can be, You can try different ways. They don't have to be necessarily, I'm ready to start full-on treatment today. But I think if somebody's categorically, no, I'm not interested in, I'm completely pre-contemplative, I'd probably not worth shoving it in their pocket, you know. But so there's probably an in-between area. Thank you.
So I chatted about the ACCESS trial a few rounds ago, and we're nearly ready to start going with that. Cardiology's on board. This is a trial looking at patients with out-of-hospital cardiac arrest who had an initial shockable rhythm and have a pulse in the emergency department that we'd normally send to ICU. And we're going to randomize people to code STEMI activation versus usual care, which is going to the ICU. So we're going to put up some posters in the trauma bay, and the process will be for the emerge doc to call on-call research assistant who will tell you which treatment strategy the patient will be randomized to. Send me any questions, concerns.
Outstanding. So let's talk about some recent.
One question. Hopefully we'll start April 1st.
Brian, it's 24/7.
24/7, yeah. Rob?
Sorry, I gotta get this to work. That's the way. Yeah.
Sorry, Frank. I just want to put in a plug for the SSTI study. That's not STI. Julian, by the way. So, the skin is soft tissue cellulitis study essentially is actually starting. I know I've talked about it for the last couple of months, but it's actually starting within a week or two. So it's anyone you're going to start intravenous antibiotics on, and then they get randomized either intravenous or oral for 5 or 7 days. There'll be a research assistant sort of overseeing all of the logistics. So nothing really for the docs to do except to be aware of it.
Alrighty, that's what's starting. Here's some recent outputs here. Garth, senior author to Garth, I think he's still seeing patients in fast track. Senior author to manuscript in academic emergency medicine, talking about our 4-hour versus 10-hour paper performance rule. Karine.
I quit CrossFit for 10 minutes last year and did a bit of a PoCUS study, which was accepted to resuscitation. And we randomized candidates to check pulses using ultrasound versus palpation, and wanted to do a non-inferiority trial and to determine whether that was any slower or not. And it turns out that ultrasound is no slower given the setup. So if ultrasound is turned on, probe's gelled and you're ready to go. Ultrasound is no slower and better to do a pulse check.
Nicely done. David has something from geriatric assessments.
We had I was a co-author on a paper in academic
Alrighty. So Shannon didn't respond to her email about this, but I know she's got a paper in CGIM about HIV exposure. That's part of the tech grant that she got a couple of years ago. So good work for Shannon for, while, trying to manage Kevin and 3 other kids, trying to get this done as well. Good for you, Shannon. Brian's got some unpronounceable thing here. Brian, do you want to explain this?
Yeah, so this is a study looking at patients out of hospital cardiac arrest and using this criteria that had been proposed for which patients would never survive despite any resuscitation attempts. So there was an age criteria and then non-shockable rhythm and unwitnessed arrest. And out of like 30,000 patients, there were a handful of survivors, so way under 1%. So implications being for paramedics in the pre-hospital setting, whether they might consider not even starting resuscitation in these patients.
And that's some resuscitation, right? So here's a slightly bigger one.
Yeah, this is just it wasn't a study, it was more of a commentary in circulation on some ethical issues with eCPR patients in terms of getting consent and then also how long to continue treatment and issues with differences between medical teams and families with regards to how long to continue therapy for.
So Brian's too modest to point this out, but this is in Circulation, which is a much bigger journal than resuscitation is. So congratulations on a really important topic that we sometimes skirt around a bit. One more paper. Oh, there's Shannon's paper. One more paper here, Outcomes in Long QT, which I got just published. Basically, if you have long QT, your 30-day mortality rate is 5%. If you do not have long QT, your mortality rate is 30 days is 5%. And if you have extreme long QT over 500, your mortality rate is 5% at 30 days. So anyway, after some, this is an academic emergency medicine. So this is just a wrap up from the last 3 months of what our group has had published either as first or senior authors. So we've driven the majority of these studies. We're not just hangers on these studies here. And the other thing I should put up there, I got lucky enough to be a co-applicant on a CHR scholarship for $125,000 run out of Calgary dealing with chest pain. That's the one scholarship award we have for the past 3 months. Are there any questions about future projects or recent outputs that we can clarify? In that case, I'll turn the proceedings over to Kim.
I just say a congratulations to the research group. You've done an amazing job, and I think it merits a little bit of applause.
Okay, sorry, I forgot to introduce myself. I'm Nav Gurewal. I work at Mount St. Joe's, don't work at St. Paul's, for those who don't know me from there. So our first presenter today is Dr. Kim Chi Nguyen, who's going to be talking to us about an ultrasound topic. So take it away.
Hi everyone, my name is Kim Chi. I'm one of the CCFP grads out of Calgary from last year and one of the ultrasound fellows here in the department. And today I'm going to be talking to you about point-of-care ultrasound in the evaluation of syncope. So objectives today, we'll talk about just the brief evaluation of syncope that we do in the eMERGE, the role of point-of-care ultrasound in the syncope assessment. We use PoCUS for a number of chief complaints, namely a lot of different things actually. So we reach for it when we see patients with chest pain, with dyspnea, NYD, or in shock as well. So I was just using this grand rounds as to dive into what else we can use it for and what kind of protocols, if any, are out there for syncope evaluation with PoCUS. And we'll talk a bit about hypertrophic cardiomyopathy at the bedside and whether we can diagnose this at the bedside potentially. So life-threatening causes of syncope. Syncope accounts for about 1% of all the ED visits that we see, and about 10% of these patients will have some sort of life-threatening cause of their syncope. Cardiac syncope in particular is a very common cause for why patients will have an adverse outcome after we discharge them from the eMERGE. just a brief primer on what kind of things on your history and your physical examination might tip you towards a potential cardiac cause of their syncope. So anything that occurs during exertion or supine, the potential presence of structural heart disease that's evidenced by any sort of family history of sudden cardiac death or an abnormal ECG that the patient might have when you see them. Sudden onset of palpitations immediately followed by syncope or any ECG findings suggesting an arrhythmic cause of syncope. So in your assessment after your detailed history and physical examination as well as a 12-lead ECG, this decreases your rate of unexplained syncope to about 10 to 15%, depending on what literature you're looking at. And in terms of clinical decision rules, there's not any CDR sensitive enough quite yet to predict any serious risk of adverse event following a syncopal episode after you discharge patients from the ED. So what is the role of syncope in your assessment? The physical examination in 2019, so the 4 pillars traditionally of physical examination are your inspection, palpation, percussion, auscultation, and there are some advocates out there that are advocating for instination afterwards, so adding on ultrasound as part of any physical examination maneuver that you do in the ED. But just because we can do PoCUS on patients, should we be doing it? Or will it end up being one of those things we do for no particular reason in the ED? There are harmful consequences to doing these types of things. TTE is not the same as the PoCUS or the advanced cardiac views that we do in the eMERGE, but PoCUS that we do for absolutely no reason at all, even though we may not think about it particularly, can lead to things like delays in the ED flow, patient as well as physician anxiety about things that we see on PoCUS that we can't exactly interpret in the context of why we're seeing those patients, as well as downstream investigations and consults that might be triggered by us doing PoCUS in the ED. So this study here looks at was an ED-based study, a retrospective study with looking at consecutively enrolled patients presenting with syncope in the ED, and they divide these patients up into no risk versus risk groups. No risk being pristine physical examination, history, and ECG for no reasons suggesting a cardiac syncope, and anyone in the risk group has any of those things in terms of concerning history, physical examination, or any sort of abnormality on ECG. All these patients either both the risk group as well as the no risk group, went on to have TTE performed by cardiologists or a sonographer. And this just hammers home the point that patients who have a normal assessment when you see them really have no reason to have a TTE afterwards, and arguably shouldn't have PoCUS either in the ED. So only 1 out of 47 patients in the no risk group had an abnormal TTE. And of those who were in the risk group, 27 out of 97 patients had some sort of abnormality on TTE. What does abnormal really mean in the context of syncope? Bear with me for a second because my video isn't loading in here. But so say you see a patient with syncope and you do your cardiac views of the patient as well as you throw the ultrasound probe up to their suprasternal region as well too, and say you see this. Oops. This is an aortic dissection. Sorry?
It says aortic dissection.
Yes, there you go. So the labeled sign on your PoCUS. This is a patient that was seen in our eMERGE recently with an aortic dissection. So if you see that on your assessment and you ask yourself, is this the cause of my patient's syncope? Say on your cardiac views, you also see mild tricuspid regurg and a dilated left atrium to what it's worth, and you see an aortic dissection. Is this the cause of your patient's syncope? Oops. Probably. Big fat probably. But arguably, sorry?
Would you be able to go back and point out the dissection for us? Those of us who are less initiated.
So this is using the cardiac probe, putting the probe right up at the suprasternal notch, and the dissection flap is right here. All of this. This patient had a massive dissection, so they dissected all the way up into their carotids and all the way down to, I think the iliacs as well too. So arguably on PoCUS, the only slam dunk things that you can see on PoCUS evaluation that are probably most likely the cause of your patient's syncope are an aortic dissection, severe aortic stenosis if you're able to detect this, as well as cardiac tamponade. In that study that we talked about before, of the abnormalities that they saw on those patients who went on to have TTE in the risk group, then they had a number of these different things. So something like a large pericardial effusion, EF less than 45%, regional wall motion abnormality, or an abnormal to severe regurg of any sort of valve, moderate to severe diastolic dysfunction, severe pulmonary hypertension, or severe ventricular wall hypertrophy, or HOCM with some sort of outflow tract obstruction. And these have been identified in international guidelines as potential causes or diagnostic of a patient's syncope after all the workup has been done. These have been identified. So what as Emerge Docs are we good at identifying on this list, and what is potentially in our wheelhouse for the evaluation of patients with syncope? I would argue on this list, and we're pretty good at looking for large pericardial effusions. We're getting pretty good at eyeballing a patient's EF, saying whether it's low, moderately reduced, or severely reduced. There is lots of uptake for looking at regional wall motion abnormalities in select groups of patients, and being able to detect abnormal or severe regurgitation of any valve as well. These I've sort of blacked out because diastology is very difficult, and I still have kind of nightmares from the weekend fellowship where we did diastology. Sorry, Oron. And severe pulmonary hypertension. These patients are very complex inherently due to their physiology. So what about severe ventricular wall hypertrophy and HOCM with outflow tract obstruction? I think these are things that, as Emerge Docs, we look at an ultrasound image and something jumps out at us as to something that's abnormal. Again, I'll make this video here. So this is a patient I saw in our department here who has known cardiomyopathy, hypertrophic cardiomyopathy. So you look at this video here, and something piques your eye. Most of you will look at this and say, wow, that myocardium looks thick. So we use the next couple of minutes just to be able to quantify what thick is, what a hypertrophic heart actually is in terms of numbers, and a formalized assessment of that. So hypertrophic cardiomyopathy, about 1 in 500 people, or 0.2% of the general population, has hypertrophic cardiomyopathy worldwide. And it's estimated that 90% of these patients are unidentified. So our work is definitely cut out for us in terms of identifying these patients. There's the beginnings of a body of literature to support us using PoCUS to identify these patients, or non-expert PoCUS for hypertrophic cardiomyopathy. There's lots of case studies and case reports of people being diagnosed with HOCM out of the ED, and even pediatric HOCM being diagnosed in the ED after a previously normal echocardiogram as well. Medical students, for what it's worth, have been successfully trained to screen for HOCM after just 2 hours of didactic lectures and 2 hours of supervised scanning. But most recently, there's been this published in the Canadian Journal of Cardiology by one of our cardiac fellows here at St. Paul's, looking at pre-participation cardiovascular screening for causes of sudden cardiac death, namely right and left ventricular abnormalities, as well as HOCM and aortic root dilatation. And the type of training involved in employing this sort of thing is, in the future, using this out of the ED or in primary care, or as well with sports med physicians in screening athletes for pre-participation in athletics and competition. And so this was an internal medicine resident who was given 15 hours of training via a formal course and 30 hours of supervised scanning afterwards, so a total of 45 hours of formal training. And they reported very good correlation between a non-expert scanner and compared to formal TTE, which is promising, I would say. The pathophysiology of HOCM is complex, so there's multiple interrelated abnormalities in HOCM. But the most important thing, and the thing that should tip you off mostly for a patient potentially having HOCM, is marked hypertrophy. So if you see that on echo on your PoCUS examination, you should be very, very suspicious. The basic echocardiographic features of HOCM include a myocardial thickness at end diastole of greater than or equal to 15 millimeters, And in athletes, the literature advocates for something even, a threshold even smaller than that, so 13 millimeters or above. There's also a subtype of patients with HOCM with an asymmetric septal hypertrophy, so a septum to LV posterior wall thickness ratio greater than 1.3, plus or minus this phenomenon called SAM, or systolic anterior motion of the mitral valve, which I'll talk about in a bit. So PoCUS views, if you are wanting to look for, if you have the appropriate patient, someone who has something alarming on their history of physical examination or LVH, for example, on their ECG, take the ultrasound machine and take a look. PoCUS views for hypertrophic cardiomyopathy, I would advocate for using the peristernal long and the peristernal short axis, most importantly, looking for size. And then you can add on the IPCO 4 or IPCO 5 chamber for looking for pressure gradients and SAM, and colored Doppler of the mitral valve as well too. But the essential views are your peristernal long and your peristernal short axis. Peristernal long axis as well, you're looking for ruling out aortic stenosis, for example, for looking at another reason for why a patient might have a hypertrophied myocardium. So just to review your PoCUS views, peristernal, the probe marker is going to be, or the probe is going to be placed to the left sternal border, and probe marker to the patient's right shoulder, peristernal short, and then probe marker to the patient's right hip. If you're struggling to get the peristernal views because of patient positioning or patient body habitus or huge COPD lungs, and you can look subxiphoid as well too, something that I wasn't too familiar with during my emerge training before, but have since been introduced to during fellowship. So you can look subxiphoid as well too, which we've been introduced to before, and patients or physicians are much more comfortable using. So you can use the subxiphoid to generate a long axis view, as well as a short axis view too, that it is exactly similar to what the peristernal views would do. So with the subxiphoid long axis, it's still going to be patient probe marker to the patient right, and then for the subxiphoid short axis view, then have the probe subxiphoid with the probe marker up towards the ceiling. So to do your measurements, you're going to employ M mode in your peristernal long axis view. Then you're going to look mid LV and drop your M mode ice pick perpendicular to the long axis of the LV, just in the mid LV cavity, and then in your peristernal short axis right into the center, and avoid those pap muscles. And then you're going to hit update or M mode again to generate the waveform of one, your interventricular septum, the LV cavity here, and then the left ventricle on this side. And this is where you can drop your calipers and do your measurements here, or just eyeball it as well. It's easiest in the short axis view as demonstrated here, either the peristernal or the subxiphoid view, and measure it end diastole. Subxiphoid, you could do this as well too with the long axis view, but looking here, your long axis is a little bit off, so it's difficult to get the M mode ice pick exactly perpendicular to the long axis. So it's best if you can only generate a long axis view subxiphoid to freeze it and then cine back or scroll back using the trackpad, and then just measure using your girl calipers. So your complications of HOCM, you can look for a phenomenon called SAM. So during systole, then normally your mitral valve leaflets are going to come together to prevent regurgitation from your LV into your LA. What happens in SAM is that your hypertrophied septum causes narrowing of your outflow tract and increased velocity of blood flow through there, which causes drag forces and turbulent forces that pull the anterior leaflet of the mitral valve towards the septum instead of coapting with its buddy down below, as does normally happen in systole. This causes LVOT obstruction from the mitral valve leaflet moving anteriorly during systole, as well as significant mitral regurg potentially as well too. So if you see a heart that's hypertrophied, make your measurements and then go on to do some measurements or to look for SAM as well. To do this, you're going to look in your peristernal long axis view and use M mode again, putting your ice pick over the anterior leaflet of the mitral valve, just like that. So this is what happens normally during systole. This red box here defines the phase of systole, and this is what happens in the normal cardiac cycle, where the mitral valves will come together here and here during systole. And this is what happens during SAM. So instead of coming together, you see the anterior leaflet of the mitral valve coming towards the septum. So take-home points on syncope, history, physical examination, and ECG plus minus PoCUS in at-risk patients only, so don't go doing it in patients who have absolutely no risk factors and absolutely normal or benign family history and physical. Abnormal PoCUS findings are common, therefore use just one data point in your total clinical assessment. And remember your subxiphoid long and short axis views when you're assessing your patients if you can't generate a parasternal view. And remember those echocardiographic features of HOCM, so myocardial thickness, septum to LV posterior wall ratio greater than 1.3, myocardial thickness greater than 15 millimeters, and looking for SAM as well too if you have a patient with a hypertrophied myocardium. Thanks very much. Any questions? Yeah.
Thanks, Kimchi. Do you advocate from your review of preparing this talk that we should be doing AAA scans as part of our syncope workup too with the ultrasound outside of the TTE part?
Good question. I think in the right context, I think in patients who give some sort of history towards abdominal pain or chest pain associated with their syncope and have the right risk factors, so elderly, long history of smoking, whichever, then it could potentially add something onto there. And it's probably the one scan in PoCUS, as we've learned, that means something, and that patient does definitely need some downstream testing and some referral. So I don't think everyone you should do it in. You should do it in the patients who, again, have risk factors or some sort of history that suggests to you that they might have something like that to be concerned about. Thanks very much.
Thanks, Kimchi. It gives us another useful tool to use in investigating cardiac causes of syncope. Next up, we have Dr. Sean Hardy, who's going to be speaking to us about pressors in the ED.
This guy there. And let's just make it big. Make it large. Yeah. How do we make it large? Presenter mode. Okay, so it's in presenter mode. There we go. And how do I go forward and back?
Just use.
Can I turn up the brightness a bit?
Yeah.
There you go. Awesome. There you go. Backwards and forwards. Okay, cool. Thank you. Okay. There's like a mouse ripping around the bottom level here, and he's not big, but he looks hard. So if I like shriek or fall over or do a bad presentation, then it's the mouse's fault. Okay, so we're going to talk a bit about pressors and inotropes in the emergency department. And in the spirit of such an exciting topic, we're going to start off on an exciting note with some disclaimers. Disclaimer 1, nobody paid me anything, obviously. Disclaimer 2, I am not as smart as most, or some might argue, any intensivists. For people who know me, this is not news. I'm like cocktail party smart at best. I'm not like healthcare smart, and I'm certainly not ICU smart. But the point is that, what's that? But basically, like what I'm saying is this isn't meant to be like an ICU-focused talk. Despite overlapping with the ICU in terms of patient populations. This brings me to disclaimer 3, which is that my goal is to take a broad, nuanced subject and make it both simple and memorable. It's hard to take a subject as broad as this and not gloss over some stuff or generalize a bit, which I've definitely done here. Even so, the point of this talk is to distill recent evidence, and in some cases a lack thereof, down to things you'll remember at 3 in the morning when a patient is crashing. There will almost certainly be some points worthy of debate, and I think that that's like a reasonable price to pay for establishing learning points that are simple and clear. Okay, for those who are interested, here's the outline. So we're going to go over a few refreshers, review some of the newest evidence, and then wrap up with some take-home points. Okay, shock. We're going to provide a bit of context by talking briefly about shock. Some of you may have heard of shock before. It's known to be an early warning sign for the development of other serious conditions like death. And there are tons of slightly differing definitions of shock that exist, but this one's pretty classic. A state of inadequate perfusion where oxygen delivery to the tissue fails to meet tissue oxygen demands. Comes in 4 delicious flavors: hypovolemic, obstructive, cardiogenic, and distributive. I know there are other schemas for classifying shock, but this is by far the most common one that we see. And we're going to go through them really quickly. So hypovolemic shock, basically, most often we'll see this in the context of hemorrhage, whether traumatic or not, and there are some other causes. But hemorrhage is by far the most common. Cardiac output is down because, as we know, there just isn't enough gas in the tank. And we see that reflected in a decreased preload as well. Systemic vascular resistance is increased in an effort to perfuse the vital organs with whatever is in the tank. And so typically we see these people as being cold in the extremities, clammy and peripherally shut down, although not always. Obstructive shock, very similar. So basically the idea, as the name suggests, is that there's something impeding forward flow or venous return, and the hemodynamics are actually very similar to the profile that we would see with hypovolemic shock. Again, these people tend to be peripherally cold and shut down, at least in the later stages of shock. Cardiogenic shock, so as we know, this is usually an issue of pump failure, often caused by things like valvular disease or severe heart failure. So cardiac output is decreased, preload is often up, and patients are once again peripherally clamped down. Distributive shock, so this is a little bit of a heterogeneous category, and it comprises a few varied shock etiologies, including things like anaphylaxis and neurogenic shock. But I think that sepsis is usually the one that's most relevant to us, especially here. Cardiac output can be up or down depending on the etiology. Preload is usually down, and of note, systemic vascular resistance is usually down, which can be a tip-off, as these people will sometimes be warm in the extremities, peripherally sort of opened up. There is a fifth cause of shock, or a fifth category that we can look at. Definitely my favorite, and this is undifferentiated shock. This is sort of like the Brian Epstein of shock states, pretty underappreciated, but important nevertheless. Even so, any emerge doc worth their salt knows that a patient should be in undifferentiated shock for as little time as possible. And that a good assessment should hopefully help to clarify things and remove this question mark from over the patient's head. We'll come back to these later, which I'm sure is a relief for everyone who wants to hear more about the categories of shock. But I think that we can spend another minute or so now on diagnosis. So this can be a little bit tricky, and it evokes I don't remember if it was a Supreme Court justice or something trying to define pornography, saying, I don't know how to define it, but I know it when I see it. I think that that's the approach that a lot of people take in the emergency department. And it can be tricky because no single feature is sufficient to diagnose shock, and sometimes the presentation is variable. But this is from Rosen's. I think it sums things up pretty well. The emergency clinician identifies shock by linking the qualitative clinical impression to quantitative data. This is something that most of you know already, but I think that it's worth going over even so. You can see on the right-hand side we have some of the more qualitative stuff that you might see, things like hypotension, tachycardia, mottled skin, etc. And then down below some of the more sort of hard physiologic parameters that might be used to guide you in the direction of diagnosing shock. Okay, so shock, to just summarize, 4 delicious flavors plus another one, and diagnosis relies on qualitative and quantitative information. Okay, we're going to go over vasopressors and inotropes really quickly. This is not going to be a comprehensive list, but I want to point out a few things before we get into the sort of nitty-gritty. So a distinction is made between inotropes, which increase cardiac contractility and rate. I know that's technically chronotropy, but often these are grouped under the inotrope label, and vasopressors, which increase systemic vascular resistance by vasoconstriction. In reality, it's more of a spectrum that we're looking at, and I'm going to get into that a little bit. As I said, the list I've compiled here is by no means exhaustive, but it covers enough of this spectrum to be representative, and I think comprises most of the agents that you're likely to see. So I'm starting kind of in the middle of the spectrum with the mixed activity agents, or inopressors as they're sometimes called. Norepinephrine, I think, is familiar to pretty much everybody here. It is pretty versatile, and it's used frequently. It has mixed alpha and beta activity, but the alpha predominates. So more than anything, you see vasoconstriction peripherally with some increase in stroke volume and heart rate. Side effects include dysrhythmias and tissue extravasation and ischemia. Epinephrine is similar, but is a little bit more beta dominant. And it is dose dependent as well. So at doses less than 10 mics a minute, we tend to see more inotropy and chronotropy, and then increased sort of vasoconstrictive effect above 10 mics per minute. Dopamine functions at alpha, beta, and dopaminergic receptors. Again, dose dependent. And as you can see from the little profile that I've got there, really you see basically increasing vasoconstrictive effect and vasopressor effect as you get higher up on the dose. I've bolded dysrhythmias there just because it is noteworthy. Things like the SOAP2 trial and others have highlighted the concerns around dysrhythmias with dopamine, so we'll come back to that. Okay, inotrope dominant. So dobutamine, synthetic catecholamine, has mostly beta activity at a 3-to-1 ratio of beta 1 to beta 2. So primarily it's inotropy with some weak chronotropy. Also increases myocardial oxygen demand. Keep that in mind because cardiac ischemia can be a concern. Milrinone functions by PDE3 inhibition and increases cyclic AMP. So inotropy, again, similar to dobutamine, very weak chronotropy and a little bit of vasodilation as well. So these are sometimes called inodilators. You might have heard of that. Hypotension can be a concern, so do not bolus this ever, as well as dysrhythmias and torsades. It's also renally clear, so keep that in mind with renal patients. Okay, finally, vasopressor dominant agents. So the one people probably know best here is phenylephrine. Pure alpha-1 agonist, so pure vasoconstriction increases systemic vascular resistance. You can get reflex bradycardia with it, though, in hypertension. And vasopressin, to finish off, functions at its own V1 and V2 receptors, and again, increases systemic vascular resistance. It's a good vasoconstrictor, so it does that more than anything else. Okay, a little summary here of what we just talked about. And having said all of that, my goal up until this point has been to basically get everybody on the same page, refresh people a bit, and sort of prime us to discuss some of the more pertinent and current information that we have regarding the use of pressors and inotropes in the emerge. Okay, so in terms of exploring the evidence, we're going to start with central versus peripheral administration, because I think that that's sort of a relevant question for all of us, and considerations around this issue. So a question I've often found myself asking, and this is sort of going to be the format for the rest of the presentation, is it safe to administer vasoactive agents peripherally? So the truth is that unfortunately, when it comes to rigorous study of this issue, there's just not an absolute ton of stuff out there. Maybe most frustratingly, I looked in earnest into this idea of, say, like a hard limit of 10 mics per minute of peripherally delivered norepinephrine as a sort of a hard line, which seems to be the case for anybody who's sort of rotated through the ICU. I was trying to sort of figure out what the rationale behind that sort of hard limit was. I couldn't find very much, unfortunately, or really anything about the dose-dependent effects of peripheral administration of any of these agents. But what I did find was this. So this is from 2015, a systematic review of 85 articles, mostly case reports, so I think we have to keep that in mind. And they were looking at complications like extravasation, tissue injury, and found low rates overall. Most complications, I think it's worth pointing out, happened after 6 hours of administration of the agent, and 85% of complications occurred at access points distal to the antecubital fossa. And they actually pretty much looked at almost all of the agents that I mentioned earlier. Beyond that, I found a few other individual studies that have since been published, most notably this prospective observational study from 2017, which landed on essentially similar conclusions. And finally, this very well-cited 2015 consensus guideline from CAPE, which will be recurring here, said something much the same in terms of sort of both vasopressors and inotropes administered peripherally for short-term use. So, is it safe to administer vasoactive agents peripherally? Yes, but there's a big, sad kind of buzz-killing asterisk next to yes in this case, because I think that from what I've seen, all of the recommendations in favor of peripheral administration are pretty conditional, and in most cases the consensus seems to be it's probably fine, but we should probably study this more rigorously before we bet the farm on it. But still, I'd say conditionally just fine. For how long? So less than 2 hours, I think, is playing it safe. You could stretch this to 6 and justify it on wobbly footing. but it would mean acting like a little bit of a cowboy, and I know that that just isn't our style here, so keep it to 2 hours to be safe. Anything else to consider? Sure. So, as that systematic review said, consider kind of more proximal sites of administration rather than distal, because that's generally associated with less complications. Push-dose pressors. Yeah. So this went a lot better in my head when I was sort of in the middle of planning this talk. I thought, I'll just sort of dig up the evidence on how great they are and how well they work, and everyone will love me, and I will have a chance to bask in the adoration that I so deserve. And that would have been really great. But instead, I got this shit, so enjoy, I guess. So this was brought to us in 2015 by somebody named Scott Weingart. I don't know, never heard of him. In any case, he fancies himself something of a critical care expert, and he seems to have been one of the first champions of push-dose pressors in the eMERGE. Primary agents proposed have been things like phenylephrine and epinephrine primarily, with ephedrine being studied as well. So basically what he proposed around sort of, this was published in 2015, but he had it kind of going back in his MCRIT blog as far as sort of 2013, 2014, was essentially using boluses of pressors and inotropes for certain indications in the eMERGE, as has been done in operating rooms for years. Indications included things like peri-intubation, procedural sedation, and as a bridge to infusions, I think most notably. That's really small, sorry. Has the efficacy of push-dose pressors in the eMERGE been proven? This is the question. So one of the first review articles to look at the existing literature about this was this one here from 2016. Actually comes from the nursing literature. They felt that evidence supporting the efficacy of push-dose pressors in the eMERGE was pretty lacking. What they did find, and what you'll find if you with a quick Google search, and what most of the literature on this actually refers to more than anything else, is the abundance of foam-based or expert opinions. So we see it in blogs, we see it in podcasts. Scott Weingart talks about it quite frequently. I'm not going to go into, so they said that there was some moderately compelling data from the obstetrical and anesthesia literature. I did a little bit of a deep dive into that stuff that they cited. I had a whole paragraph here that I'm going to cut out for time reasons, basically taking those studies apart because they're not very good. Methodologically, they're all pretty flawed. So I'm going to say requires further study is the conclusion from this article, and that's sort of what they say themselves. This came out in 2015, dealing specifically with peri-intubation phenylephrine boluses, and they wanted to see what it did to hemodynamics. It improved hemodynamics, shockingly, but they found that there was little systemic practice consistency, and again, further study was required. This was from 2018. It was a case study in which 3 fluid unresponsive patients responded well to epinephrine boluses post-cardiac arrest, so good for them. And in 2016, this came out looking primarily, again, at peri-intubation treatment of critically ill patients. Their outcome measure was basically initiation of pressor infusion within 30 minutes of bolus administration, and this happened for 46.5, so slightly less than half of patients studied. Similar kind of study design from 2019, just a couple of months ago. So they were looking at ICU patients. This was not in the eMERGE, but again, predominantly peri-intubation. Same outcome measure as an endpoint, and 28% required pressor infusions following use of push doses. So has the efficacy of push-dose pressors in the eMERGE been proven? I have a feeling that this is going to inspire some debate, but I'm going to say not especially, and we will come back to this. But at least push-dose pressors have a good safety profile, right? Right? Not really. So the Rotondo et al. Study from 2019 recorded an adverse event rate of 11.6% and a medication error rate of 11.2%. The Schwartz et al. Study that I mentioned from 2016 recorded an adverse event rate of 20.5%, which seems astronomically high. This is based on, as some might say, over-inclusive definition of adverse events, which I won't get into here, but they were reaching a little bit. So it should probably be taken with a grain of salt, but We also need to be realistic in looking at the somewhat fraught history of bolus dosing of vasoactive agents, both inside and outside the emerge, when it comes to these issues, medication errors in particular. I didn't include it here, but there are some good case studies which came out in the last year or two, looking at specifically a bunch of medication administration errors with bolus dosing that all, of course, as you'd expect, are off by a factor of like 10 or 100 or 1,000. So like somebody getting 50 milligrams of phenylephrine instead of 50 mics, 100 times the amount of epinephrine that they're supposed to get. I have no doubt that that will give people some zip, but I don't think that that's really what we want to be striving for in the emergency department always. This article came out in 2018, and you'll be happy to know it actually took a productive stance on the issue of bolus dosing safety, rather than just whining about everything. Even so, they did take the opportunity to whine a little bit, because as they pointed out, this practice is largely unregulated and practitioner-dependent in the emerge, which I think we all sort of know anecdotally, which for the sake of patient safety should be reframed as a more consistent and structured practice. So that was sort of their message. So push-dose pressors have a good safety profile. No. You suck, you're ruining all our fun. Jenny's made a huge mistake. Jenny's my wife, by the way. Technically all these things are true. But what else is true is that push-dose pressors in the emerge do show serious potential and are backed up by a wealth of anecdotal evidence and expert opinion. What's needed now is the other half of the picture, the sort of systems and safety-based considerations that will allow us to sort of standardize these modalities and further study their efficacy and use. If you're still unclear about sort of my stance on this, this is complicated. I do have some thoughts, and I'm going to wrap this up really quick, but I think that we need to appreciate the setting and the context when we're talking about push-dose pressors, as well as their use and concerns around them. I think as they apply to us, they're a different beast than they are in, for instance, like the ICU or the OR. If they're being used as a temporizing measure or a bridge to infusion of vasoactive agents, to directly compare them to infusions in terms of efficacy, which a lot of those studies did, may be missing the point. I think that there is inherent value in push-dose pressors. And as a Hail Mary, I probably would use them, but this is something that we just need to look at a little bit more closely. Okay, going to quickly go through recommendations by shock type because I think this will be sort of money for people in the 3 a.m. sense. So hypovolemic shock, I'm not going to go through all of the things telling us to give fluids in hypovolemic shock because hopefully you know that already. There is also something called the Vitris trial, which is being studied right now. And it's actually directly comparing basically fluids with and without epinephrine in like traumatic hypovolemic shock. So it's a pretty big study. The results aren't out yet that I've been able to find, but that should be coming to us pretty soon. So basically fluids, and actually I sort of glossed over those studies there. But if fluids alone aren't cutting it, norepi is probably what the evidence tells us we should use. Cardiogenic shock. So the 2015 CAPE recommendations suggest as a first-line norepi and dobutamine as a second agent if one is needed. This consensus statement from 2015 with a lot of letters attached to it suggests again as a first-line norepi and then for decreased cardiac output dobutamine. The AHA in 2017 suggested as a first-line pressor norepinephrine. This is all pretty consistent. And then Long et al. In 2018 suggested, again, for hypotension, norepi, dobutamine for decreased cardiac output. So which agents are recommended? Norepi plus or minus dobutamine. Obstructive shock, again, I'm not going to sort of belabor this point. A bunch of different individual case studies exist sort of looking into this. But we don't really have a wealth of evidence comparing different agents or anything like that. CAPE was super helpful and said, in obstructive shock not responding to indicated treatment, a systemically active vasopressor should be instituted. Thanks, CAPE. So basically dealer's choice is what I'm going to say. But as I'm going to come back to, really it's, in this case, as we all know, it's addressing the underlying driver more than anything else. Septic shock. So I'm going to give this a fairly wide berth. David Sweet covered this fairly extensively last month. But basically what he reviewed about pressors and inotropes specifically hasn't really changed since the surviving sepsis guidelines in 2016, 2017. So norepi is the first line, and then if you need a second agent, vasopressin or epinephrine. Belletti et al. In 2017 actually looked a little bit at inodilators like Dobutamine in septic shock, and it showed some promise in terms of mortality benefit, but it's not enough to hang our hat on yet, so we need more study there. And then CAPE, from their 2015 recommendation, suggests as a first-line norepi, and in catecholamine refractory shock, vasopressin, decreased cardiac output, Dobutamine. So septic shock, norepi plus or minus vasopressin or epinephrine is what I'd say. Anaphylactic shock, this is going to surprise everybody. They recommend epinephrine, but give it early. That has not changed. Epinephrine, very exciting, epinephrine. And then undifferentiated shock, I think that this is relevant. From the CAPE 2015 recommendations, they actually they address the issue of undifferentiated shock and suggest it's a first-line norepi, based on some pretty good stuff. And then this pretty big Cochrane review from 2016, looking at kind of all-cause shock, actually found no pressor or inotrope proven to be superior to the others, but this mostly echoed what the SOAP2 trial looked at in 2010, which is kind of looking at the concerns about sort of risk profiles of these medications, and they basically said dopamine not as good as norepi on the grounds of higher risk of dysrhythmias, so they recommended norepi. So norepi would be what I would use. Take-home points, finally. So my goal was to take a broad sort of nuanced subject, make it both simple and memorable. Hopefully I've done that. I think that there's room for lots of discussion around this subject. But take-home points are essentially appropriate use of pressors and inotropes requires a strong understanding of the etiology of the shock, including multiple etiologies that are overlapping, which often happens, and the available agents that we have. Different shock states may benefit from different treatment strategies. So hypovolemic shock, fluids, norepi. Obstructive shock, dealer's choice, non-pharmacologic stuff, deal with the driver. Cardiogenic shock, norepi, dobutamine. Septic shock specifically, norepi, and then either vasopressin or epinephrine. And anaphylactic shock, epinephrine. Undifferentiated shock, norepi. Is it safe to administer vasoactive agents peripherally? It is, but with some caveats. Less than 2 hours if you're going to do it, and give it proximally if you can. Verdict on push-dose pressors, questionable efficacy, definite risks, more studies needed. These are my tiny references. Any questions? Assuming they're nice. And thanks, Nav. Yes?
Thanks, Sean. That was a really good review of those agents. And one thing that's quite notable, actually, is for those of us who've been around for a while practicing, is that dopamine has kind of disappeared from the list. Should we even be stocking it now?
I don't necessarily want to tell the stock people what to do, but I mean, I think that the evidence is pretty compelling, especially the SOAP2 trial that I mentioned, which I didn't specifically sort of bring up on a slide here. But that looked pretty closely at this issue in terms of sort of directly comparing dopamine and norepinephrine, and essentially found them to be equivalent in terms of their efficacy, with the exception of this sort of higher risk of adverse events, most notably dysrhythmias with dopamine. So, I mean, I guess like have it around for nostalgia purposes, but otherwise, I don't really see a reason. Yeah.
Just from an ambulance perspective, they have new treatment guidelines for the ALS crews based on the new AIM course. And you'll see that they use something called a shock index. So if their shock is heart rate over blood pressure. So if their shock index is under 1, they're good. If it's over 1, then especially peri-intubation, they give phenylephrine. If they're in cardiogenic shock and they think that they're braddying down or just about to code, then they'll give epi, like 10 mics infusions. So you'll be seeing that in intubated patients coming in.
Oh, cool. Any other questions? Nobody's angry about the push-dose pressors? It's kind of
Can I ask a question from VGH?
No.
I was just curious where your recommendation of peripheral pressors for under 2 hours came from, because I was aware of some studies where they did it like up to 72 hours and there was really no issue as long as it was a good enough IV. And so I've certainly been doing it for longer than 2 hours, and I was wondering if that's bad, I guess.
No, but I mean, again, like the big asterisk next to my recommendation is definitely noteworthy there. So, the long and the short of it is that this is something that we should study more rigorously, like generally speaking. As I mentioned, that big systematic review of 85 studies was mostly case reports. So our information is out there. It's not super robust, and in that study they found pretty much that, yeah, you're right, like in a lot of cases they were able to run these pressors for multiple days peripherally without many issues, but they did kind of, I think, play it a little bit safe, and their recommendations were a little bit conservative in terms of, for instance, 85% of complications happen distal to the antecubital fossa. The majority of complications happened, after 2 hours, and I think that there's a big range there between 2 hours and like the really kind of far end of how far some people might push it. But I think it's a little bit nebulous. Like, I don't think you're wrong. Does that help? That doesn't help at all, does it?
No, that's a great answer. Thank you.
Okay.
I just have one comment on the same thing.
Yeah.
Thanks, Sean. I think on the 2 hour, this is an area I've looked into also in that study, and I don't think I would stick to a hard and fast 2 hour line either in terms of peripheral pressors, in part because doing a hasty line is actually going to be more risky for the patient than the very small risk of other stuff. And so this is so context dependent. What else is going on in your department? Can you afford to fully prep and do a really good line in a patient? So I think we're going to get ourselves into trouble in the department, or even perhaps for that patient with line complications, if we obsess about 2 hours of peripheral pressors. So I think based on the Lubani stuff, we have at least a 6 hour window. And then when that patient is in a controlled environment in the ICU, they can have a central line there. If it's not that busy and you have time and you have the resources, absolutely do it in the ED.
Totally. I think I selected toward the most conservative possible numbers in an effort not to rock the boat too much. But in theory, I completely agree with you. It makes sense. The evidence is compelling in terms of being able to run these things longer, and there is definitely a risk of doing other stuff that's bad by doing a hasty central line, as you say. Also, the complications that they found, things like extravasation and tissue ischemia and stuff. A lot of the time they were able to treat these things with phentolamine, and it was like these were reversible complications, so not the end of the world. So again, yeah.
Great. Thank you so much, Sean, for taking a very broad and interesting topic and breaking it down nicely for us. The next resident is from our Nanaimo pilot program at Nanaimo ER, Dr. James Liu, who will be talking to us about Aboriginal health and implicit bias in the ER, which ties in nicely with this morning's provincial rounds. And then once he's done, we have a quick presentation from Dave Barbeck, 1 minute presentation. And that'll be it.
And just pardon me for one moment as I switch the slides. All right, it's on there. Great. Hi, my name is James Liu. I'm one of the Emerge residents based out of Nanaimo. And today we'll talk a bit about Indigenous health in the context of the emergency department. And emergency physicians are amongst the most frequent providers of Indigenous health. And this can be an incredibly rewarding component of our work. However, some do find that the complex determinants that affect the patient's presentation, as well as the upstream determinants and challenges outside the emergency department, to be difficult to manage in a fast-paced ED environment. And this can be compounded by the episodic nature of the ED visit. However, because of the degree of marginalization that Indigenous Canadians experience, any small gains, even small gains in the aspect of emergency care with Indigenous patients can have significantly large gains. And so we'll focus on one issue today that has significant impact on Indigenous health, and that could be tackled through the emergency departments. And so we'll be exploring the issue of implicit bias in the context of care in the ED. In terms of disclosures and acknowledgements, I'd like to first acknowledge that today we're here on the traditional and unceded territory of the Squamish, Tsleil-Waututh, and Musqueam nations. I do not possess any lived experience as an Indigenous individual, as I am an Asian settler, and I do not have any additional conflict of interest to disclose. It is already widely known that Indigenous Canadians have overall poorer health status compared to non-Indigenous Canadians. You'll see displayed here, life expectancy for all Canadians is approximately 81.7 years at birth. This is compared to Indigenous Canadians at 75.7 years with a 6-year gap. And that puts Indigenous Canadians, in fact, on par with the life expectancy of Hungary, which is significantly below the OECD average of 80.5 years. Other markers of health status includes neonatal death, as well as mortality after MI, diabetes, rates of suicidal ideation, all significantly higher amongst Indigenous Canadians. This illustrates an entire population within Canada that's reaping limited benefits of the advanced societal and healthcare infrastructure that we do have. The well-known determinants of health contribute to the poor performance on health status indicators. As you can see, Indigenous Canadians are systemically disadvantaged across almost all determinants of health that you see here: proximal, intermediate, and distal, in a remarkable demonstration of structural violence. I'll just highlight one example out of the determinants in here, that's income. As you can see in the gray bar, that represents First Nations Canadians in First Nations communities. Green represents total Canadian population. There's almost a negative linear relationship as the income brackets increase towards screen right. You'll see decreasing number of First Nations Canadians in each income bracket, and this is certainly not the case in the green bar representing total Canadian populations. In addition to the increasingly known trauma surrounding residential schools, as well as the 60 scoop, there are also examples of other historical injustices that were perpetrated directly by members of the healthcare system. And that includes the Indian hospitals, which were created to treat often specific diseases, often infectious diseases such as tuberculosis. However, they essentially function as quarantines, and very little, unfortunately, is known in literature about them, but this is increasingly known through numerous publications that have come out recently in the form of books. So poor experiences and reports of abuse have contributed to lasting distrust as well as stigmatization of certain diseases. Other examples include the nutrition deprivation experiments, which were performed in the 1940s to the 50s. These were done, funded by Canadian government and done by government researchers to identify the effects of malnutrition. And over 1,300 Indigenous children were experimented upon, including those in Port Alberni. Injustices also are not limited to the past, unfortunately. Brian Sinclair is a gentleman who passed away in the Winnipeg Emergency Department after waiting for 34 hours after presenting with a bladder infection sent in by a family physician, and was found to have died by another patient in the waiting room after being unattended for 34 hours. External review found this to be a preventable death and identified racism as a significant contributing factor. A review performed in 2017 looked at the issue of coerced surgical sterilization with reports out of Manitoba over the past 20 years, found 16 women who were willing to come forward and who felt that they were coerced into having tubal ligation either during labor or reported that they were not advised that tubal ligation is a permanent procedure. And the external review by a lawyer as well as a health scholar identified, again, racism as a contributing factor. Unfortunately, explicit racism by physicians is also an issue that's been identified. Here's an example of a woman holding a prescription with a drawn beer bottle with crossed outs. This was presented to her as a prescription folded up for abdominal pain. She was unaware and thought that this was a genuine prescription, and returned home and found the drawing. These occurrences have the potential to affect the degree of trust towards the medical system amongst each of our patients, whether or not they have personally experienced any of these events, or whether or not they perceive any of that directly from the provider in front of them. It still affects their healthcare experience. And so in summary, when caring for Indigenous patients, they're based on what we talked about earlier with the health status, we know that there's a higher pretest probability of disease. Based on the determinants that we discussed, there may be effects of multiple risk factors. And finally, there may also be experiences that impair trust towards medical professional amongst our patients. And so the emergency physician, it is incumbent upon the emergency physician to have a high index of suspicion and to demonstrate effective and efficient use of cultural sensitivity in order to build good therapeutic rapport in a time-limited setting. And so as emergency physicians, we are in a position to alleviate health disparities or potentially perpetuate or even contribute to health disparities. So what is the experience like for Indigenous Canadians in the emergency departments? What we do know is a survey suggests a perception of lower quality of care received. Qualitative studies have identified that many patients feel judged based on the legitimacy of their presentation, their requests, or their socioeconomic status. Here are two quotes from qualitative studies. "I don't really like coming to the emergency department, but where's a guy supposed to go, you know? And again, is it because I maybe look like a street person? Maybe it's because I'm Native. I don't know. They treated me like crap, and I know it was because I was Native. We all know because of the look. There's a look. When you need the medical care, we put up with it. We shouldn't have to. We bleed the same way. We birth the same way. We have no choice." Regardless of what the actual occurrences were in each of these healthcare encounters and what caused them, the perception of unequal and discriminatory treatment can further damage therapeutic alliance. So this begs the question, is there objective evidence of disparity in the healthcare experience that is provided? In the United States, there is. There's well-known numerous studies that demonstrate racial disparities in emergency department length of stay, in analgesia for appendicitis, in the rates of lab and radiographic testing, in triage acuity scores, and the proportion leaving the emergency department without complete care. In Canada, there's unfortunately very limited evidence, limited studies that were done, and even fewer that are done specifically examining the Indigenous experience. There is, however, one recent study published in the Canadian Journal of Emergency Medicine in January of this year that looked at a group of Saskatoon emergency departments with regards to abdominal pain CTAS-3, comparing First Nations individuals to non-First Nations individuals. They found that there were no difference in time to analgesia or time to a physician, which is encouraging. However, there's a few significant limitations. One, there's a statistically significant difference in the portion of individuals who left without being seen. 8% in First Nations, status First Nations versus 0% in non. And as we know, the proportion leaving without being seen is in fact a marker for quality of care. The very reason why someone left without completing care may be that they have experienced discrimination, or in this case, maybe because they were waiting long. The mean time of those who left were in fact longer than the mean time of the studied population, and so that does introduce a degree of question. First Nations individuals were identified by status number, and this is a significant limitation, as we know not all people identifying as First Nations have status numbers, and this could cause a misallocation in the study, although none were specifically demonstrated. And we also know that there's evidence that non-majority races are often put at a lower triage score compared to majority races to begin with. So again, these are all limitations. However, this is one data point worthy of considering, and it is encouraging at this point. So looking at this issue of racial disparity in healthcare in the United States, the Institute of Medicine recognized implicit bias as an issue, as a contributor. So what is implicit bias? Well, it's a phenomenon where stereotypes unconsciously affect our individual understanding, actions, and decisions. And this can affect us to create favorable or unfavorable assessments without conscious awareness or control. And this is, there are certain advantages to implicit bias, and that is it allows people to make efficient decisions, and it can automate certain thoughts, which are desirable processes. However, as you can see, for the rest of the presentation, we'll talk about its negative implications. And this is also distinct from explicit bias, which is in the realm of conscious control. So what about implicit bias in the emergency department? So we know that activators of implicit bias are fatigue, time constraint, information overload, and the requirement to make quick decisions with limited information. Does that sound like the experience of the emergency physician in the department? There's significant association between ED overcrowding and higher post-shift implicit bias scores. And so what I'm trying to demonstrate is that the emergency department is an environment that facilitates the engagement of implicit bias. The state of the literature is that very few, as I mentioned earlier, few studies examine in Canada the disparity affecting Indigenous Canadians, and most of the studies are done in the US or Australia. Implicit bias itself is a growing area of study, and very few studies correlate implicit bias directly with health outcome, which is a significant limitation at this stage in the game. Many studies are done outside the ED setting, and many are done using vignette studies rather than real-world testing. And however, there are some broad stroke conclusions that I'll acknowledge up front, and we'll go into more details. The vast majority of studies on systematic review demonstrate evidence of a pro-white bias amongst healthcare professionals. The level of pro-white bias is similar between healthcare professionals as well as the general population. And in studies that did look at correlation, they did find a positive relationship between level of implicit bias and lower quality of care. And so we'll look at the impact of implicit bias in three domains: communication, medical decisions, as well as health outcomes. I will be using the terms, as I did, black and white, etc., to indicate race. This follows the usage of these terms in racial bias literature, but I would contextualize it in this context only, and I wouldn't necessarily advocate for the use of these terms outside this context. I'll also acknowledge that most of these studies, in terms of measurements of implicit bias, is done with the implicit association test, which I won't go into details other than to say that essentially it's got good psychometric properties, and it measures the association between concepts. The strength of their associations is determined by reaction time. There are some criticisms about the implicit association test methodology, and that it is possible to be faked, and that different versions of it exist, and some versions find implicit bias in almost all subjects tested. However, as I mentioned, it is a primary tool. It is a primary tool that is used in research, and it does have good psychometric properties. So in terms of impact of implicit bias, so it's been shown that explicit bias affects the content of conversation, whereas implicit bias affects nonverbal forms of bias, such as eye contact or speech errors, etc. Greater clinician implicit bias is linked to, in encounters with Black patients, clinician verbal dominance, lower liking of the clinician by the patient, lower confidence in the clinician, and lower likelihood of recommending the clinician to others. Encounters with white patients, show that there's a higher likelihood of being perceived that they're being treated with respect. However, there's also a lower likelihood of finding the encounter to be participatory. So overall, as we can see, bias favors white patients. However, there are some caveats in that it feels less participatory. Interestingly, a discordance in explicit and implicit bias is perceived poorly. So of all people studied, those people who have low explicit bias and low implicit bias are perceived quite well by their patients. Interestingly, what follows that are the people who have high explicit bias and high implicit bias, so people who were outwardly racist. They were still, even them, they were still perceived better than clinicians who demonstrate low degree of explicit and outward bias, but have high degree of implicit bias. They studied this issue in oncologists as well and found that, again, implicit bias is negatively associated with patient interaction, but it wasn't just the patients. It was also identified by observers that are observing recorded videos. Because of our dependence on communication to obtain a history and the potential impact on adherence, impaired communication has a potential to cause significant impact even if other aspects of the encounter were not adversely affected by bias. So the next section looks at medical decision-making. There's arguably fewer evidence in this area compared to the other. In the literature, there are a number of negative studies and a number of positive studies. I'll highlight the positive studies. When clinicians were primed with images of black faces, they reacted more quickly to stereotypical diseases. These are outside just the ones that are genetically disposed, like sickle cell, but also conditions such as obesity or substance use. Under higher time pressure, physicians with high implicit bias against Black and Hispanics gave less serious diagnosis to these groups, and they're less likely to refer to specialists. People are less likely to prescribe narcotic medication to African American children compared to white children. And again, biased physicians are interestingly more likely to treat white patients but not Black patients with thrombolysis when presented with typical scenarios representing myocardial infarction. There's, again, now down to health outcome, there's very few studies in this area. In counties, American counties with higher implicit prejudice overall by postal code, Black mothers experience higher rates of preterm birth and low birth weights compared to a comparable group of Black women. There is one study that looked at spinal cord injury patients, and so physicians who demonstrated racial implicit bias was associated with patients having disabilities in social integration, depression, and life satisfaction, but interestingly, no effect on physical health outcomes. So what is the way forward? We'll take a look at some of the strategies that emergency physicians can do to improve care and address implicit bias. We'll look at point-of-care strategies which you can use on your next shift, as well as some more comprehensive strategies that are more aimed at addressing the determinants of bias rather than the point-of-care strategies that more so look at mitigating the effects. But first, reach under your seat and find a free prescription of propranolol. I'm kidding, of course, but interestingly, 40 milligrams of propranolol is associated with decrease in implicit bias. Alternatively, you can go tanning and turn your skin dark, because there's also studies demonstrating self-perceived darker skin tone experience decreases implicit bias. So I highly recommend it. Cognitive forcing strategy. The first thing that I would recommend that everyone does on the next shift is to assume that implicit bias is present. And of course, this would be a fairly valid assumption based on what we just talked about. Once you've assumed that implicit bias is present, we can then focus on ensuring and demonstrating to ourselves that we're doing everything we can to mitigate the effect of the bias. We already do this. If you don't want to, when tapping the ankle and you don't want to hit the artery, you find the artery first, and then you tap the ankle. So if you assume that bias is present and you take steps to mitigate those risks, you're less likely to cause injury. Individualization, so focus on seeing each patient as a unique individual as opposed to a representative of the broader population. And you can do this by focusing on the social history and involving family members, and just thinking that the only things that you know about the patient is what he or she tells you. And even the things that we went over in this presentation today, these are generalizations and may not apply to the individual patient that's in front of you. And so ask who they are and what their experiences are. Stereotype replacement. So recognize within yourself stereotypical responses to interracial interactions. And there are what we went over earlier: limited testing, anticipating poor adherence, or non-patient-centered communication style. And instead, I'm asking you, instead of being blind to race, to see race and use race as a cue to being an opportunity to address the 6-year gap in life expectancy that we talked about earlier, by replacing it with a more effective response, such as focusing on communication. And I would recommend using and committing to using a structured approach to enhancing communications, such as going back to medical school or using FIFE or any other acronym or any other structured approach that you use. But we know that we rarely utilize those modalities in the emergency department because of time. However, we likely implicitly focus and put more emphasis on using excellent communication strategies with patients that we already have good rapport with. And those, unfortunately, based on the studies, are more likely to be white patients. And so even if there were equality in that we don't do a structured approach such as FIFE in anyone, there is an inequity in its effects which disproportionately affect Indigenous patients. So I would advocate that you selectively utilize a structured approach to improve communication, such as FIFE. We already do this in pediatrics, such as using the HEADS assessment. We know that it is difficult to have conversations about sex with teenagers, but we force ourselves to do so because we know about the risk factors, and hence we should be applying a structured approach to pediatric encounters, as we should in Indigenous patients. The more sustainable strategies that I would suggest would be increasing meaningful interactions by, for example, establishing meaningful friendships with people outside one's own demographic in order to develop true and healthy respect and admiration of people outside of your own demographic. This gives an opportunity to develop counter-stereotypic imaging. Inherently, if we don't purposefully do this and learn about people that are outside of our own demographic, our impression of Indigenous population is based on what's dominated in media and other stereotypes. And inherently, as a physician, when we treat patients, we are likely treating patients to an imaginary endpoint. And that imaginary endpoint is what we think the person came in with. This becomes really difficult to do if you've never been able to imagine an Indigenous person as well, functional, and dignified. And the only way to do that is to see people outside of the times in the emergency department when they're most vulnerable, and the impression that you have already formed by establishing meaningful personal interactions. Wrapping up, looking at perspective taking. So I think it is crucial outside of the ED setting to learn about the oppression and the trauma that's faced by Indigenous Canadians, because there are studies that demonstrate oppression there are studies demonstrating that providers often have more bias towards patients when we perceive patients as being responsible for their own health problems. So it is essential that we learn about and understand the risk factors and the determinants at play. Here are some aspects of additional training that I would recommend, including trauma-informed practice, as well as cultural safety and humility training. And so in conclusion, emergency physicians are amongst the most frequent providers of Indigenous health in Canada. This provides us with a unique opportunity to alleviate health disparities and potentially address the 6-year life expectancy gap that we talked about earlier. However, the emergency department is highly predisposed to implicit bias, and emerging evidence suggests that there is significant impact on patient care. Because communication and therapeutic alliance is the final conversion point of everything that we know and that we do in medicine, it is crucial that we address any barrier affecting this juncture. And by acknowledging our biases and making a conscious effort to mitigate its impact, we do have an opportunity to make a true contribution to reconciliation in Canada. Thank you very much. And thank you to Dr. Mike Bergrunder for reviewing the slides for me, and Dr. Grewal for facilitating.
Questions? I just want to thank you so much, James. I thought that was a really well done presentation on experience we don't talk about our department. It's such a huge part of our career.
Thank you.
So I think that about wraps it up. I think Dave was going to give his presentation at the practice plan meeting instead, so we are done. Thank you.